almost 20 to 30% of the patients having AF also have concomitant coronary artery disease, CAD, while 5 to 10% of the patients undergoing percutaneous coronary intervention, PCI, have AF. Choosing the optimal antithrombotic therapy for these patients with multiple conditions is always a challenging task for you. With the consideration of high bleeding risk, how should we use aspirin, clopidogrel, and oral anticoagulants based on available clinical evidence? So now we want to share with you a landmark study, the Augustus trial, which can provide you more insights for that. Augustus is the largest prospective randomized trial to investigate, in a blinded fashion, the risk and benefits of aspirin on top of non-VKA oral anticoagulant and P2Y12 receptor inhibition. More than 4,600 patients from 492 sites and 33 countries were recruited in the study. It is a prospective, multi-center, 2x2 factorial randomized clinical trial comparing apixaban with a vitamin K antagonist and comparing aspirin with placebo in patients with atrial fibrillation who had a recent acute coronary syndrome or underwent PCI or both. Its unique study design enables us to determine whether the benefits in bleeding reduction were due to use of a non-vitamin K oral anticoagulant or removal of aspirin, unlike studies done previously. The two main objectives of the trial are to 1. Determine whether apixaban is non-inferior to VKA for the combined endpoint of International Society on Thrombosis and Hemostasis, ISTH, major and clinically relevant non-major, CRNM, bleeding. 2. Investigate, in a blinded fashion, the risk and benefits of aspirin on top of a non-VKA oral anticoagulant and P2Y12 receptor inhibition. Here is the result of the Augustus trial. For the primary outcome, the proportion of patients with ISTH major or CRNM bleeding was significantly lower for those treated with apixaban than for those treated with a VKA, while the rate was significantly higher in patients receiving aspirin compared to those receiving placebo. For the secondary outcome, the rate of all-cause death or hospitalization was 17% lower with apixaban versus VKA, while the rate was similar between the patients receiving aspirin and placebo. In conclusion, an antithrombotic regimen that included apixaban without aspirin resulted in less ISTH and CRNM bleeding and fewer deaths or hospitalizations, without significant differences in the incidence of ischemic events than regimens that included a vitamin K antagonist, aspirin, or both. Now that you have seen the evidence from the Augustus trial, what would you choose to be the optimal antithrombotic therapy for your AF patients with a recent ACS or undergoing PCI?